Hi everyone, I'm back again for another episode of Ask the Egg Whisperer. You're probably like, didn't I just see her yesterday? And the answer is yes. I love answering your questions. I think I have over 500 if I were to check the Ask the Egg Whisperer website right now. And I'm super motivated to help each and every person who reaches out with a question. Reminder here that the questions and answers that I'm giving you guys are not in place of great advice that you're going to get from your own personal physician. This is just for entertainment. No, I'm just kidding. I'd like to think that I'm entertaining, but at the same time, I'm just giving you some questions to ask your doctor so you feel a little bit more empowered. I mean, I literally have people that reach out to me and they say, Dr. Aimee, I'm so scared to ask my doctor this question, so I'm going to reach out to you instead. I'm like, okay, well, don't be scared. And I said this the other day, and I'm going to say it again here today, that if you feel like you're being annoying, you're doing a good job as a patient. You're advocating for yourself and you're asking questions. So here we go. Let's get started. This is Kristin's question. I am 39 years old, undergoing my first IVF cycle and currently preparing my uterine lining for transfer. After 2 weeks of taking estrase, 2 pills 3 times daily, my uterine lining only measured 4.8 millimeters. My doctor increased my estrogen by prescribing patches, 2 patches that are replaced every other day. After 1 week of using the patches and pills, my lining increased to 5.5 millimeters. My doctor wants me to continue on this protocol for another week and see what kind of progress we make. What causes a thin uterine lining? What thickness do you recommend for transfer? What can I do beside medication to increase my lining thickness? So Kristin, this is not an uncommon problem. This is one of the challenges that we as fertility doctors see pretty frequently. So there are a lot of different things that your doctor will do for you. And it sounds like they have lots of tools in their toolbox and they're pulling them out and they're trying them all. So in a case like yours, I would ask, I wonder if I have ruled out Asherman syndrome or uterine scarring. So if that's not, if that hasn't been done with a saline sonogram or a hysteroscopy or a hysterosalpingogram, that's an important test for you to ask your doctor about. So just say, what have you ruled out as possible causes of my uterine lining thinness? I know that's a whole lot of words, but that's one way of saying it. I'm sure you're going to do a much better job, Kristin, at saying it than I just did, but you know what I mean. So if you've ruled out Asherman syndrome or scarring of the uterus as a cause, the next thing to do is say, is there something about my lifestyle that could be contributing to this? So I've noticed that women who are really, really thin, sometimes they don't grow lining as easily. I've also noticed that women who are on the curvier side may not absorb the medications as well, and their lining doesn't thicken easily. So talk to your doctor about that. Say, what can I do that's in my control to increase the chances that my lining will thicken? I don't know everything about you, but if there's something that your doctor knows that I don't, perhaps they can make suggestions. Some other tools in my toolbox are estrogen injection. An estrogen shot every 3 days sometimes can make all the difference. And then look at the protocol. How did you start your medications? Some women are super sensitive to birth control pills. I am one of those women. I cannot handle birth control pills. And that's why I'm just very prejudiced against them when it comes to my protocols, because I can't take them myself and they make me a little, in the head, just maybe a little bit off. And so I don't want to do that to my patients. I always talk to my patients in advance, but I'm totally digressing here. But my point is this. The way birth control pills work is that they thin out the lining. So it's very possible that one of the reasons why your lining is thin is that you're on birth control pills first before you started the estrogen, and that may not have helped in your particular situation. So you might just need to stop everything, induce a period, and start over without birth control pills. Birth control pills are great for a lot of reasons. They have non-contraceptive benefits, and then I know you guys all know the contraceptive benefits, but in my world, we're using them as fertility planning pills. Sound counter intuitive? Yes, I know. But we use them to plan frozen embryo transfers. So they fall on a certain date. But in your case, I don't know, maybe reconsider using them. And the last thing, because I love talking about this, and I know I need to get on to the next question because you guys are chatting so many awesome questions. The last thing is vitamin E, L-arginine, and aspirin. So those are 3 things that you can start taking as well. So thank you for your question, Kristin. Now I have a question from Felicia. Felicia says, I had my second IVF retrieval today as my previous failed, with my embryos arresting on day 3. We started out with 12 and only 4 matured and 3 fertilized. Today, only 8 were retrieved, and the RE told me that I had a lot of follicles and many were empty. He said most of the 8 had little feeder cells. Can you explain what that means? And can an embryo successfully develop from that? I'm 37 and my husband has no sperm issues. Thank you so much. So Felicia, again, this is an IVF challenge that fertility doctors are used to seeing. And I've seen it before too. You expect so many eggs and then you're just like, I don't understand. Like, why didn't I get and recover an egg per follicle? And I'm like, I'm doing a really good job. And I go through all the things that I usually go through with my patients. And sometimes it still happens. And I just call that human biology. And certainly there are variants that we can inherit from our mother, our father, that can cause things like this to happen. And I wish I could do a test on you to see if you had one of those things so we would understand your biology even better. Because the truth is, most of these answers are in our DNA. However, there are things that we could possibly do in a case like yours. And here are the things that I would consider doing. Maybe let your eggs grow a little bit longer. Maybe 20 to 22. This is what happens when your brain is saying something and your mouth can't catch up. Okay, guys? So maybe 20 to 22 millimeters in size. Maybe increase this trigger shot dose. Look at the time that you gave yourself the trigger shot and the time that you did your egg retrieval. Those are the kinds of things that I think through when I'm thinking about what can I do to get the most number of mature eggs for a patient of mine. And then the other thing I would say is ask your doctor about what kind of supplements they recommend for you and your situation to improve egg quality, because it certainly seems that this might be an egg story. And also ask what other genetic screens they think that you might benefit from. Does it make sense to do a chromosome analysis perhaps? So I hope all of these tips help. And Felicia, I certainly hope that this batch of eggs has at least one golden one in there. So it sounds like 8 were retrieved. So there is a good chance that this next cycle that you're in right now will help you reach your goals. Great question. So this next question is from Jessica. Jessica says, my wife and I are going to inseminate at home. I'm a little confused though. I've been reading that you should inseminate when the cervical mucus resembles egg whites. Does the cervical mucus appear like egg whites before or during the LH surge? And when would be the best time to use frozen sperm to inseminate? So this is what I would say, is the cervical mucus is a sign that ovulation is coming, maybe in the next 3 days or so. So paying careful and close attention to the cervical mucus is very important. Depending on how many vials you have, you can do more than one insemination at home. So I know these sperm vials are very expensive, but perhaps consider getting 2 or 3. Maybe do one ahead of ovulation, maybe do one on the day that you see the peak, maybe do one a day or 2 later. So that might be a strategy that can help, especially if you've done several inseminations at home already. And be sure to also think through the Tushy method. Make sure the tubes are open, there's no fibroid blocking things. I've seen this before where people are inseminating at home, spending so much money, only to find out after they've had enough that there was, let's say, a polyp or a fibroid in the uterus. So I would strongly recommend that you talk to your OBGYN and say, pelvic ultrasound, please. And ask for an ultrasound before you do your next insemination, just to make sure we're not missing anything like a big cyst or something structurally wrong with the uterus that could be getting in the way. And then the other thing is, if you're doing inseminations at home, also make sure that the sperm source and your wife's eggs are genetically compatible. So look at the carrier screen from the sperm donor and see and make sure that your wife has had the same testing done so that there's no issue with passing on a recessive disease. So this next question is from Melinda. Hi, Dr. Aimee. I'm Melinda. Hi, Melinda. I feel excited to get a quick response for you for my IVF questions, which I emailed to you. Now I'm following up with you. Here are my questions. I'd like to have more details. Oh, this is fun. Melinda, I appreciate you, but Melinda, I'm going to answer your question next time because you're referring to a great email that I'm sure you sent me, but I don't have that email in my Ask the Egg Whisperer little portal thingy. But thank you, Melinda. I'll get to this next time. I promise you. And you guys, I don't want you to miss me too much, so I'll probably be here again, maybe tomorrow. So this next question is from Nadine. And Nadine is saying, hi, Dr. Aimee. Appreciate your time and expertise. Thank you, Nadine, for being so kind. I'm 45 in mid-November and have had 2 canceled no response IVF cycles, and the last one having no egg in the one follicle. That sucks. I'm sorry, Nadine. With a 1 to 3% chance given for success of a 4th cycle, I'm lost as to call it quits or try again. My doctor doesn't really want me doing it unless it's with donor eggs. If we do, however, she would use the same mini-stim plan as the first 2 involving estrase, androgel, clomid, Seza, Menopure, and Provera. I heard that Omnitrope and Menopure together and taking away Menopure, but the doctor is away for a few days and I was hoping to get your feedback. So Nadine, you know what I say. This is what I would say to you. I would say, look, if you really need to do one more IVF cycle, that's fine. That's totally fine. But I want you to ask yourself this question. If this next cycle also doesn't work, would you have wished that you would have done and just moved on to donor eggs? And if the answer is yes, then just go on to donor eggs. But if you still need that experience and still need to get the closure before you move on to donor eggs, I don't see how it could hurt you. I mean, I just feel bad for all the trauma that potentially these cycles could be causing you. And if you guys know me, you know that I often say that your mental health is the most important to me when you're starting your fertility journey and throughout. And when patients ask me, Dr. Aimee, what's the complication rate from IVF? And I'm like, the complication rate's actually really, really low, like 1% or less. But the issue is the complication that no one talks about is the effect on our mental health, causing anxiety, depression, PTSD. And I don't want to get down or make you guys depressed or sad, but I know everyone who's watching me right now knows exactly what I'm talking about. And so I don't know necessarily that if you were my patient, I would encourage you to do another cycle. But if you felt like you really needed to, I would be like, I'm all in with you. And I'm going to believe in your fertility. And I'm not going to do any type of I told you so dance. But I'm going to tell you that it might be time. Okay, great. Thank you, Nadine, for letting me answer that question. Because I know I actually get this question a lot from a lot of people all over the world. So this next question is from Anya. Hello, Dr. Aimee. I wanted to thank you for all the wonderful sparkle that you add to this journey. So thank you. Oh, and that brings up something. I have a patient who sent me this beautiful gift. I thought I'd share it with you. It's the Egg Whisperer, Dr. Aimee Avazadeh. At the bottom, it says sparkle every day. So she sent me some personalized stationery that I thought was pretty darn cool. And I'm so excited to open it up and start using it. So thank you for that. So Anya says, my background, I'm 42, almost 43, with non-interfering fibroids, controlled hypothyroidism, and an AMH of 3. Pretty good, Anya. In the past year, I had 2 unsuccessful IUIs and 3 rounds of IVF. In March, I got 20 eggs out, 1 genetically normal from 5 embryos. In July, 16 eggs out, 0 normal from 3 embryos. And then in August, no embryos out of 10 eggs. I also had moderate case of COVID in May and was sick for a month. My 1 normal embryo will be transferred in 10 days. I did an ERA, which is pending. Here are my questions. Between now and the transfer, how do I optimize my success? Is it advised I stop any supplements prior to the transfer, CoQ10 and melatonin? Any thoughts on whether having COVID could have impacted the poor outcomes in my subsequent IVF after a great first start? Or is it more likely just age? So these are all great questions, Anya, and I'm going to go through them one at a time. Your first question about how to optimize transfer success. So I think the best thing is to ask yourself, if this transfer didn't work, is there anything that I would have done differently before I do this transfer? And the other question is, what would I do if this transfer didn't work? And I think that's also a really good question to ask your doctor. You say, hi, doctor, I'm Anya. I'm sure your doctor knows who you are. And you ask your doctor, if this transfer didn't work, what would we do differently next time? Because sometimes those things are the things that you would do now. But if you were a patient of mine, I would make sure we've looked at the cavity, we've looked at preconception labs, we've talked about, have we ruled out adenomyosis or silent endometriosis? And I might even bring up the following. I would say, you know what? I really want you to be a mother with your own eggs. Does it make sense for us to use a gestational carrier? I know you guys are like, what? But sometimes it makes sense. Doesn't make sense in everyone's case, but I think it's important to say it out loud because you've worked so hard for this one embryo and you want to make sure that you've thought through this first so that no matter what happens, because we're dealing with human biology and everything is just a chance, and just being genetically normal doesn't mean everything is normal and the embryo is going to implant 100% of the time. It means probably over 50%, and you can ask your doctor what your implantation rate will be. But that would be my approach. Look at your diet, look at your body size, look at the home. And what I tell patients is this, is that guest is the most important guest coming to your home in your lifetime. So what do we do with our homes, right? I mean, if Lady Gaga was coming into my house, I'd be like, oh my God, it's Lady Gaga. And I would be like cleaning the house and probably, putting up new paintings and like making sure everything is perfect. Like literally, Lady Gaga, call me. I want to freeze your eggs. But my point is that that's how I think of every single transfer. And so my patients obviously get that energy from me and they think of things in the same way. So for you, I would just look at everything in your house, not literally in your house, but you know what I mean. Your relationships, your stress levels, what's going on at work, and just make sure this is the perfect time so that no matter what happens, you don't call me up and be like, I think this didn't work because I had that meeting that I took the day after the transfer and I shouldn't have, and I got in a fight with somebody and it was a really bad argument and I got too stressed out. Like, those are the things we just want to clear from our schedules right now. Okay, thank you for allowing me to answer your question, Anya. That was a great question. This next question is from Aimee. Aimee says, hello, Dr. Aimee. I'm 39 years old. You guys, Aimee has had 9 failed transfers. I noticed that all of my embryos tried to implant, but they failed to develop. I often had positive lines on pregnancy tests at home, but my HCG levels on the official blood test on the day I was testing came back at 5 or less than 20. So basically I had a lot of chemical pregnancies. I've been diagnosed with severe adenomyosis. What testing would you suggest me to do before I'm going into a frozen embryo transfer cycle? And what are your best protocols for patients with adenomyosis? Okay, Aimee, this is the thing. We are so lucky, and I don't know where you live, that we have so many amazing endometriosis experts in this country. So one of my favorites is Dr. Cameron Najat. He's at Stanford. And if you are a patient of mine, I would have you go see him. And the things that we would be talking about with him are, does it make sense for us to get a pelvic MRI if you haven't had one recently? And if you've had one, is it recent enough? Should we consider a laparoscopy? And should we consider medical management before transferring? And before we do medical management, and a lot of you guys already know what that is, that includes medications like Depo, Lupron, and Orilissa. Before we start medical management, perhaps we go get more embryos. Because you know the 3 questions. What do I want? What is it going to take to get what I want? And am I willing to do it? And so if you want, I don't know how many kids you may already have, but if you don't have any yet and you want more than one, it might make sense to do more embryo freezing first. And then one last thing. You've had these chemical pregnancies. We don't want to assume that it's all adenomyosis. Sometimes when you make assumptions like that, or assume it's because of your age at 39, sometimes you might miss big picture issues. So make sure to go to angelmethod.com, go through the 5 things everyone needs to know if you've had miscarriages. And I know, like, some people say, oh, biochemical is not a miscarriage, but BS. As soon as I tell someone they're pregnant and then I tell them they're not, it feels like a tremendous loss. So I want to make sure, medically speaking, I'm not missing anything, like an autoimmune issue, something anatomic. In your case, it sounds like you have adeno. But what if there's a hydrosalpinx in the fallopian tube? That's another question to ask your doctor. Is there a chance, or have you ruled out a hydrosalpinx? Because that could be one of the reasons why you're having a biochemical pregnancy. And then you can also consider other options that are more creative to growing your family, like using a gestational carrier, depending on what you find out after reviewing everything with an endometriosis expert as well as your doctor. Okay, guys, I'm going on to the next question. This question is from Lacey, and Lacey says, hi, Dr. Aimee, I love your show and what you do. Thank you, Lacey. I'm 38 years old with an AMH of 0.9, FSH of 15, LH of 5, my progesterone 22. I've had 3 unsuccessful IUIs, and I'm starting on my IVF adventure. My question is this: would fresh or frozen transfer be better for someone like me? Okay, Lacey, here's the deal with fresh versus frozen. You guys have all heard my spiel before. I'm going to tell you now. Fresh is just as good as frozen, and frozen is just as good as fresh, unless your doctor thinks that fresh or frozen is better for you. I know that seems silly, but I assume your doctor will know how many kids you want and what is it going to take for you to get there, and if you have what you need for you to reach your goals. So in a case like yours, I would say, let's wait and see how many embryos you get first. And if you're so lucky to get several, then it seems like fresh might be a good idea. However, if making sure you have a certain number of embryos for future kids is something that is really important to you, then it might make sense to freeze your embryos, maybe do genetic testing on them, find out what you have, and then plan a frozen embryo transfer from there. You don't want to assume that the embryos you have frozen are going to be genetically normal, and you might be upset when you're ready to use them in 2 years or 3 years from now, and you find out that they didn't result in a healthy pregnancy. You might have wanted to have the opportunity to freeze more while you still had healthy young eggs. And yes, I do call a 38-year-old healthy and young. So I hope you see yourself the same way that I see you, Lacey, and be sure to take your CoQ10. So this next question is from Nicole. Nicole says, hello, I'm entering my 2nd egg retrieval. My first cycle yielded 7 eggs and I got 3 blasts and 3 transfers, all failed, no PGT testing. I took 75 of Menopure, 200 Follistim. For my next protocol, they're recommending 300 of Menopure only. What are your thoughts on this? I've never heard of a Menopure only cycle. I'm 34, AMH2 BMI normal. I have unknown secondary infertility. Main drivers that I don't ovulate on my own or regularly. Thank you. So here's what I'm thinking, Nicole. Your doctor is very similar to me, and I know that you're not my patient because I do Menopure only cycles, or at least Menopure very dominant on almost everybody. And I bet your doctor is doing Menopure only because they have a very similar experience or have similar experiences that I have with beautiful embryos with Menopure only or mostly Menopure cycles. So in my experience, I feel like if you use more Menopure than the FSH component, and for those of you who don't know, Menopure has both FSH and LH in it. I have seen in my hands, of course, just because I'm saying that this is so doesn't mean that like everyone needs to go do this. So I just want to make that very clear. Your doctor will have their own special sauce that they really are comfortable with, and we want to go with that, not just something that I'm mentioning here. But it's possible that your doctor agrees that Menopure only cycles could possibly, and I keep saying possibly, result in better quality embryos for you. And the reason why, remember, diagnosis before treatment is the egg whisperer way. I had to plug that. Since you shared with me that you're not having regular cycles or ovulating regularly, it could be because of something called mild hypothalamic amenorrhea, and your doctor probably knows that. And that's why they're using more Menopure, which is a combination of those two hormones to help your eggs grow. So thank you for that question. This next question is from Aimee. Aimee, I love your name. Where did you get it? She says, hi again, Dr. Aimee. Thank you so much for your advice a couple months ago. We just finished our 5th IVF cycle, and we finally have 2 PGS normal embryos. I am in shock. That is awesome. Great job, Aimee. We're preparing for a December transfer. I had a saline sono in August, all clear. I'll have an ultrasound right before beginning my transfer meds. I've also had, just so you know, 2 transfers in the past. That first one resulted in my son in 2017, and unfortunately the second one resulted in a miscarriage at 8 weeks of an untested embryo. My new fertility doctor wants to stick with the same protocol since both of my 2 transfers were technically successful. I just turned 38 and I do have mild endometriosis. I had a surgery in 2013 to confirm that, so this makes me nervous. Should I continue with the same protocol? Is there anything else I should do before transfer? Okay, Aimee, so 2013 was kind of it was a while ago. And so I think it's important to ask your doctor, have you ruled out endometriosis in me again? Should we treat it medically? Should I consider another laparoscopy? And also ask about the Receptiva DX test. So I think looking at the implantation rate and the quality of each embryo, I think is really important. You've been through so much. This is your 5th cycle. So please, and I know you're not doing this, but don't let anyone take these embryos for granted. So I would say take your time, consider the ERA test with the Receptiva DX test, okay? And then from there, make some decisions as to whether you should rule out a hydrosalpinx. You know, if you've had surgery, what I tell people is even if God touches you, you can have scarring, okay? And you did have a risk factor for scarring, which is a laparoscopy. So maybe look and do another HSG to rule out a hydrosalpinx, build it into your implantation testing cycle. Make sure on the HSG they get a really good look at your cavity, and then regroup after you get those results back with your doctor to see if you should stick with the same protocol or add another little something to improve your chances. And I'm just trying to be funny. Okay, but I know I'm not that funny. So this next question is from Shay. Shay says, would you recommend going through the ERA before an FET, even if you previously got pregnant twice before? One was natural and one was from a fresh transfer. Both ended in early miscarriages before 8 weeks. And the answer, Shay, is this. Frozen embryo transfer protocols are often medicated and controlled, meaning we're trying to just mimic something that naturally happens, which is ovulation. We're trying to look at genes that are expressed around implantation time. And so the transfer and the fresh transfer and the natural pregnancy you had, like there isn't anything from those experiences that I could take and apply to the rules that I would use in designing a frozen embryo transfer cycle protocol. So the ERA test basically tells us what time to show up for the party. It gives us a number, and it says show up at this number of hours after you've started progesterone. Ooh, I kind of like that analogy. I should use that more often. So I would say the decision to do the ERA really is all driven by your embryos. Let your embryos talk to you. See how many you have, see if they're going to help you reach your goals, And then ask yourself, is it important for me to do it? Would I be upset if I didn't, if this transfer didn't work? And so if the answer is, I would be upset no matter how many embryos I had, if it didn't work, I mean, we'll always be upset. And I wish I would have done it first rather than doing it second, then I would say, go do it. Okay. And also talk to your doctor and see what they think as well. So this next question is from Jamie. Jamie is saying, I'm currently 36 years old. I had one natural pregnancy at 26 with a different partner. I tried to conceive for 8 months prior to seeing my fertility doctor. I had all labs, normal HSG, no ovulatory problems. My husband's 30, had a normal semen analysis. I had 2 failed IUIs and moved on to IVF. My numbers prior to my egg retrieval last year were AMH of 1.1, FSH 4.8, estradiol 61. I got 11 eggs, 9 mature, all fertilized, and we ended up with 3 untested day 5 embryos. Our fresh transfer with a 5AA embryo resulted in a miscarriage at 8 weeks. Our second frozen embryo transfer ended up in our 3-month-old little girl. I had my appointment with my fertility doctor this week to make a plan for when we should transfer our last embryo, 5BC. I'm still struggling with the diagnosis of unexplained. All my doctor can tell me is DOR is the reason I can't conceive. If I'm ovulating an egg every month, how is that the problem? I'm considering another retrieval as we would like to have another baby and don't want to run out of eggs. Great questions. I go through this all the time with my patients as well. So Jamie, here's what I would say. At 36 years old of age, and you know what you want another baby, what you have to ask your doctor is, what is the implantation potential of 5BC? I would tell you in my practice, the implantation potential is exceedingly low. I generally don't freeze 5BCs. And so talk to your doctor about what the pregnancy rate is. Every clinic will have slightly different grading criteria. So just because I say that doesn't mean that it's the same in your clinic. So with that information, I don't want you to waste precious time. My bias in a case like yours would be to talk to your doctor about what you can do to improve egg quality, supplements and HGH priming, for example, do a repeat semen analysis, do all your preconception labs, and then do another IVF cycle before you do a frozen embryo transfer. That would be my advice to you. And then you could potentially even transfer the 5BC, like be a little creative. So you can transfer the 5BC 5 days after the egg retrieval and just see what happens, just so that, no embryos left behind, or you can just wait and then plan your next steps after you get results from this next cycle. And that's kind of, I'm just sharing with you my tips and what I would tell my patients if we were in this situation together. And this is something that I see often. So I hope the advice that I'm giving you is helping. And then you asked a couple other questions about DOR. And so the explanation seems like it's egg quality driven. And these egg quality issues are most often age related. Again, they're genetic things that we can inherit. And I tell people it's in your DNA, but there's no test that I can offer people anymore. There was a company that had testing looking at fertility genes, but unfortunately we don't have that company, the testing anymore. So I can offer it to my patients and give people answers on a piece of paper. So I wish I had better explanations other than just saying it seems like it's DOR. And then the next question is, if I'm ovulating an egg every month, how is it the problem? So the issue is each egg at 36 has about maybe a 30% chance of being genetically viable or have the ability to turn into a healthy pregnancy. And so through IVF, we can obviously grow whatever your cohort is in that cycle and hopefully get at least one healthy egg from you, especially because you're young at 36. So this next question comes from Julie. Julie says, my first frozen embryo transfer was supposed to be a medicated Lupron cycle. I ovulated, but it was cotton time, so we transferred, and I continued the PIO shot. The transfer was unsuccessful. Then we tried a natural cycle for an ERA, but it was canceled due to my cyst and my follicles not reaching maturity, 16 millimeters. We're now trying an ERA medicated cycle with double the Lupron. Thoughts on this approach? The added step of the birth control makes me anxious, since if everything goes well, it'll be 4 months before I transfer again. Julie, I totally get it. I mean, when I meet patients, my style is like, what are you doing tomorrow? Because I know that every single day and every period just feels like, not to get too graphic, you guys, like stabbing, it's like a knife in the heart, right? Every period just is so painful. And I have patients that they literally know exactly how many periods they've had since they started trying. And I think probably 90% of fertility patients know that. So, waiting 4 months just feels like eternity. But I would say your ovaries just have a different plan in mind for us. try and consider this as a really fun adventure. Not so fun, I know. Who wants to get poked and probed and all those kinds of things and all the hormones you're on? But what you actually described to me is an experience that I have had too. Maybe 1 or 2 patients a year their ovaries will do this to me also. And it is so frustrating where you're like, I put a belt on you and your pants still fell down. And I put a belt and suspenders on you and then your pants still fell down. And then when you showed up next time, I'm just kidding. I don't know what kind of analogy to use from there, but that's basically what the estrogen is. It's like a belt on your pants. It's supposed to prevent you from ovulating. And you add the Lupron to also prevent you from ovulating in people who still ovulate with the estrogen. So I think the protocol approach that your doctor has you on is definitely something that I've done before as well. And I think that there's a really good chance that it's going to work for you. So I really hope that I'm right. So this next question is from Elise. Elise says we had a baby that miscarried in January. And I'm sorry about that, Elise. And I'm glad that you're sharing your story here with me. I had a blighted ovum at 5 weeks and 2 days, but I started bleeding at 8 weeks. Then tried for 6 months and no luck. With research, I realized for my age, we probably need PGT testing in IVF. I'm 41 years old. So what I did was an egg retrieval and I got 1 PGT normal embryo. Then I got pregnant with the frozen embryo transfer. Then at 7 weeks, there was no embryo inside the sac. Something went wrong again. My doctor says sometimes inner cells differ from the trophectoderm that they biopsy from. For PGT, though, that's very rare. So the question is there anything else I could be doing? I'm 41, I already have children, but I still feel like I want to complete my family with 1 more. I'm on medications and I take supplements and I do acupuncture and my husband's 49 and he's on supplements. So her question is, should we just keep trying to find that magic egg? So Elise, I feel for you. I know that everyone's time of being done with completing their family is different. Like for some people, they're done after 1. You know that saying, 1 and done. For some people, even after 4, 5, or 6 children, they still feel like there's another one waiting for them. So I so respect you for wanting to mother another baby after having the number of children that you have at home. My thought process is this. I still think it might be helpful to do IVF again. As far as PGT normal embryos not implanting successfully, there are a number of things that I think about in a case like that. So I would suggest you ask your doctor if you've ruled out things that are wrong with the uterus, if you've ruled out an autoimmune issue. I know your husband sounds like he's great and he has healthy sperm, but maybe rule out any genetic issues there, like a sperm DNA fragmentation test. Go through my embryo diamonds, go to embryodiamonds.com, and diamonds represents the 8 things you should know about your embryos. So ask your doctor about the quality of the embryo that was transferred. If it was a fabulous embryo, your doctor is right. Sometimes PGT testing does miss small abnormalities because the platform just isn't sensitive enough. And the embryo may have been called normal when it really wasn't. But at the same time, sometimes a normal embryo by PGT standards might be low quality, and that's why it resulted in the pregnancy that you had. So talk to your doctor about all those things, and at the end of the day, take CoQ10 and NAD. Okay, this next question is from Bonnie. Bonnie says, hi, Dr. Aimee. My hubby and I are 32 years old, and I get pregnant very easy. 5 times last year, and all ended in a miscarriage. And I'm sorry, Bonnie. I had 1 heartbeat at 6 weeks, 3 biochemicals, 1 blighted ovum that stopped at 2 weeks with 2 sacs. After many tests, my TSH showed to be 3, and I'm on Synthroid. Normal chromosome analysis. I started IVF. We got 17 eggs, 11 fertilized with ICSI and Zymot, 7 PGT tested, and 3 came back normal, all top quality. And I'm doing my transfer next week. Bonnie is asking, any suggestions if I have another miscarriage? What do you think is wrong with me? We're both young and really healthy and fit. So let's go back to my angel workup or angel method. Ask your doctor, have you ruled out a uterine septum, uterine scar tissue, or anything about my uterus that could cause what I've experienced? And look beyond just the cavity of the uterus and make sure you're looking at the fallopian tubes as well. Ask your doctor if you've been evaluated for antiphospholipid antibody syndrome or any genetic thrombophilias like factor V latent or prothrombin gene mutations. Look at your nutrition and your lifestyle and ask your doctor if you've also been evaluated for any diabetes. You've already been evaluated for thyroid, so I'm glad that you're being managed there. And then lastly, it sounds like you guys didn't need to to worry about the karyotype because you already did that, but maybe sperm DNA fragmentation of the sperm quality is low. Given the age of your husband at 32, the likelihood of needing that test is really low. But if you wanted to rule it out completely, I would say maybe consider doing that test. And at the end of the day, sometimes you do all the testing and everything comes back normal. But in a case like yours, it would not be unusual for me to use empiric Lovenox. What does that mean? It means using a blood thinner for no reason at all other than just to do it. Because you guys have heard me say this over and over. When I do a transfer, I always say this. I say, if this transfer didn't work, what would I do differently next time? So have that conversation with your doctor. Because one of the things that I would do differently in a case like yours, if you didn't do it this time, would be to add Lovenox. So I add aspirin to all my protocols. Most patients will take Medrol, which is a steroid, 4 days before transfer. It's not necessarily easily tolerated by everybody. And I tell everyone it is optional. So those are the kinds of things that I would do in a case like yours. So again, ask your doctor, talk to them about some of these suggestions and see what they say as well. I hope this helped, Bonnie, and I wish you all the best with your next transfer. So this next question is from Allison. Hi, Allison. She says, is Lupron Depot done for 3 months effective at combating endometriosis and adenomyosis for receptivity issues? What test do you suggest to check for receptivity? And lastly, how do I get the Lupron kit? It's out of stock everywhere. Is there an alternative? So Allison, there are places that have Lupron. There's the 3-month version. There's the 1-month version. So if you're still having a hard time, you can direct message me and say, hey, I'm Allison. I asked the Depot Lupron question, and I'll be sure to tell you where to get it. As far as checking for receptivity, I'd look at the ERA test, which I consider like the Evite for your embryo transfer party. And then the other test is the Receptiva DX test to look at, like you already know you have endometriosis. So I hope my information is helpful. So last question that I had emailed, and then I'm going to soon get to your live chatted questions. It's from Jessica. Jessica says, my last cycle was August 7th. I'd been on norethindrone since September. My transfer date is December 8th. I was told to stop the pills on November 8th. And the question is it normal to be on birth control this long? And Jessica, it's totally fine. It is normal and common. I think about BCP as FPP. FPP, yeah, you know me, right? Fertility planning pills or frozen embryo transfer planning pills, okay? So it is common. So I have patients that say, Aimee, I want to do my transfer on January 12th. And I'll be like, okay, with your next period, tell me, I'm going to put you on FPP, and then I'm going to coordinate everything so it falls on the day that you want to do your transfer. So the way birth control pills work is they just keep you at cycle day 1, cycle day 1, cycle day 1, get it? So that you're not ovulating and your lining stays nice and thin. So as soon as you're ready to start your next set of medications, you can coordinate things according to the schedule that works for you. But if you're feeling like, I don't want to be on birth control pills because like me, they make me crazy. I literally can't tolerate more than like 2 days on birth control pills. Yeah, you don't want to be in my house when I'm on them. So thank you for that question. Okay, guys, we're going to party some more here. I'm going to start at the top of the list. I'm going to try and go down to as many questions as I can get to until my feet start to go numb from sitting for so long. So this first question is from Georgia's son. Hello, Dr. Aimee. How do you supplement cyclic progesterone therapy? I only have 200 milligram pills. Do I go for the 400 milligram dose? And the answer is 200 milligrams is what I would use. When you go up to 400, sometimes it makes you feel a little dizzy, but talk to your doctor. There might be a reason why they recommend 400 for you. Emma is asking, Dr. Aimee, what's your view on picking eye color and hair color with embryos? Is it unethical, and why do some clinics do and others don't? Emma, there's no such thing. You cannot pick hair or eye color. Easy answer. So if you're with a clinic that's telling you that you can, they're lying. Eye color, hair color has to do with a number of genes. So I'm just thinking that maybe they're just pulling a fast one on you. Just maybe. If there is a clinic out there that's telling you that they can, let me know. I'll vet them for you and tell you what I think. This next question is from Lindsay. Hi, Dr. Aimee. I have stage 3 endometriosis. I'm on my second IUI. The first one I miscarried at 5 weeks. Have you ever had anyone with success with IUI and high stage endometriosis, or is IVF my only hope? I'm 22 months now trying to conceive. So Lindsay, remember the 3 questions. What do I want? What is it going to take to get what I want? What I want? Am I willing to do it? With endometriosis, especially the severe kind, guess what? It really hurts our eggs. I know you know that already. So the reason to do IVF is so you can secure options for your future. That's why I would do IVF. So let's do this. Do IVF, freeze embryos. See how many you get. And then consider IUI or trying naturally. I mean, right? there's IUI is a lot cheaper than doing a frozen embryo transfer in a lot of places. So that might be something that you consider. But I don't want you to look back and be like, oh man, why didn't I freeze embryos for myself? Because I can tell you that 100% of my patients over the age of 40, they sit here and they're like, why didn't I freeze eggs when I still had them that were healthier? And so that's something that I want you to just really think about. And if you don't do it, just know that there's no reason to like look back with regret because you thought about it right now. And so yes, I've totally had patients with stage 4 endometriosis, adenomyosis, get pregnant with IUI, but it's not as easy than for someone who didn't have those issues. So this next question is from Joyce. Hi, Dr. Aimee. I'm on levothyroxine 75 micrograms. Before embryo transfer, my TSH was 2.3. But 14 days after my embryo transfer, it was 3.3 when the HCG was 712. Is it in this situation, how much should I change to? Okay, easy. I would say maybe do 100 micrograms Saturday and Sunday and 75 micrograms the rest of the week. Talk to your doctor and see if they agree. I bet they will. But also don't just look at TSH. Look at your other thyroid hormones too. This next question is from Joyce. Oh, I actually already answered that one. Sorry about that. Have you seen a day 5 morula go on to become a successful blast in pregnancy? Abso-freaking-lutely. That is a great question. Morulas have at least a 50% chance of turning into a blastocyst the very next day. And morulas can also get a grade, meaning are they beautiful? Are they not so beautiful? And I'm very annoying, right? I mean, surprise, surprise. I know the embryologists in the lab block my calls and they're like, oh, it's Aimee calling again. As soon as I get my embryology report for the day, I'm picking up the phone. I'm like, is that morula pretty? How about that one? Is that one pretty? Because they just tell me who has a morula and who doesn't. But I'm so like invested in my patients and their success. And I'll tell you why. This morning I woke up at 5:15 for my first egg retrieval at 6 a.m. So let me tell you, I'm working super hard to do my very, very best for each and every patient. So every single embryo literally feels like my embryo too. So that morula, I want to know what the quality is so then I can guide the patient. Because if it's not a good morula, I just want to tell you up front and be like, I don't expect that it's going to turn into a blastocyst. Or I really do expect that it's going to turn into a blastocyst. And unfortunately, sometimes when I say I do expect, it doesn't happen. And sometimes when I say I don't expect, it does happen. But for the most part, my predictions are pretty accurate. This next question is from Brid. How many IUIs should you do before IVF? Last year I did 2 and then went to IVF, then 4 frozen embryo transfers, 3 failed, 1 chemical. I'm now mid-IUI, so technically my 3rd one total. How many should I do this time? That's really a personal question. I think it just depends on your diagnosis. Diagnosis before treatment, and then create a roadmap for your future and see what you're going to do along the way. What stops are you willing to make? And at some point you have to say, does it make sense for us to stop completely? I mean, it looks like you had a great number of eggs from your IVF cycle if you were able to accomplish 4 frozen embryo transfers. So maybe rethink your IVF protocol and different supplements that you can take, and hopefully it will help. But I've certainly had patients like you who have gone on to have had IUI success. As long as the sperm is good, tubes are open, and you're ovulating more than 1 egg, for example, it sounds like IUI could still be a good option for you. This next question is this. I was told today that 3 of my mature eggs have become blasts, but they aren't ready yet. Is that concerning? So the answer is, that happens. Think of your embryo like a kernel, and the popcorn has to come out in order for them to safely biopsy and freeze the embryo. You don't, like when you, I do this all the time. Like I'm still hungry, you get to the bottom of the popcorn bowl and you're just like, I still want more popcorn. I'm just going to settle for the kernels. Like you can still chomp on a kernel, but oh my God, that tastes so gross and gives you a stomach ache. Don't eat your embryos, but that's kind of like how I think about embryos that are not ready yet to be biopsied. It's like, just leave it in the microwave a little bit longer, right? So just leave it in the incubator a little bit longer and popcorn's gonna come out. And then you can biopsy it. It doesn't mean anything bad about the embryo. It just means your doctor is being super safe, as well as the embryologist, to make sure that they're not hurting your little embryo. Very little and very microscopic and very cute. That will hopefully turn into a very juicy baby with lots of rolls. This question's from Infertility Penned. Hi, I'm 32 with an AMH of 4.2, 11 eggs retrieved, and these are European units, or outside the country units. 8 made it to blast. Awesome. 4 on day 5, 4 on day 6. We decided to do PGT. What outcome would you expect with my low AMH? At 32, it could be 50% or more. I mean, I'm not tripping. Your real life experience is telling me you got golden eggs. Next question is, let's see here, from Allie. Hi, Dr. Aimee. I've heard you recommend DHEA for DOR. What about DHEA for normal ovarian reserve? AMH 2.3 but low testosterone. So this is the thing. I don't necessarily recommend DHEA for everybody. Yes, you're right. For people who have, let's say, 5 or less eggs, I sometimes do make that recommendation, but it also, like, I think about other things too when I'm making that recommendation, like their body size and stuff like that, metabolic parameters, because I think that DHEA, if it raises your testosterone, especially if it raises it really, really high, that might not be so good for eggs. So I do not recommend DHEA for normal ovarian reserve. We actually don't know normal testosterone levels for women based on age and body size, and ethnicity. So you would think that like we would have normal parameters over time and age, and like by now it's 2020, but the answer is we actually don't. So I don't think that you need to treat a low testosterone and that could cause any issues with your fertility. I just don't. It's probably related to your body size, the amount of muscle mass you have, and all those good things. So let's see here. I'm going to keep going down, and I can't wait to answer more of your questions. So this next question is from Chrissy. Hi, Dr. Aimee. I did 2 IVF cycles with no blastocysts. Would you recommend HGH? I am assuming I have bad egg quality. The answer is yes. I would definitely recommend HGH. Talk to your doctor about the quality of the embryos at the stage that they stop growing at. Look at embryodiamonds.com and look at the 8 things that I talked to you guys about, and make sure you've printed that out and go through each thing with your doctor and see what you can do to improve embryo quality, because every embryo is egg and sperm. So look at both things, egg side and sperm side, to improve your chances of pregnancy. So next question is, does it make sense to have, I don't understand that question. Okay, so next question is, who do you recommend sperm DNA fragmentation testing to? So I basically recommend it to everyone, almost everybody. Everyone over the age of 50 for sure. Guys who are over the age of 40 who have any chronic medical condition, and actually probably everyone over the age of 40 too. And then anyone with an abnormal semen analysis, and then anyone who's had, poor blast formation rate or implantation issues from IVF, even with great sperm. But lately, it's basically everyone. So my first answer is everyone. And the reason is I learned from someone, Dr. Blake Evans, and he shared with me that in his study, looking at sperm DNA fragmentation, he found that 30 to 40% of men who have normal semen analysis will have abnormal sperm DNA. And I was like, what? Like, that matters to me, because guess what? Unlike eggs, guys can actually make big differences in their sperm quality in just 3 months of time. Like, they can actually do things differently, like get out of the hot tub, stop taking those bubble baths, stop smoking the weed, put the cigarette down, stop drinking the scotch, stop eating all that pizza, right? I used to have this joke. Well, not a joke, it's actually a real thing. So I did this thing once where I called the local Domino's Pizza and I said, can we just put in a card for a semen analysis test? They thought I was kidding. I was not. Okay. So someone's asking, what do you think about the ccrm antihistamine protocol, Claritin, Pepcid, prednisone? And I say, I love that protocol. And there are lots of patients that I put on it. I can't think about the right grammar. Zymont, yes or no? Yes, if your doctor agrees. I don't want to get into the way of any doctors and what they're saying. I use Pixie a lot. I also do Zymont on some patients, and I think that it's fantastic, phenomenal. Next question is, should my doctor be doing any testing post-IUI before my beta test 14 days after? And the answer is no. I get progesterone like water to a marathon runner, so I don't need to check anything. I'm assuming your progesterone's great, so I don't see there's any reason to check anything after your IUI. Just go home and relax. This next question is Lovenox harmless? I have MTHFR and my anti-lupus was positive once. I also have endometriosis. To minimize the autoimmune issues, I want to add Lovenox, but my doctor says it's not harmless. Great question. I've been using Lovenox since, oh my God, I'm going to age myself, 2005. That is a long time, you guys. Long, long time. And I have seen one maybe complication. I had one patient that had a nosebleed so bad that she needed a blood transfusion. That is one patient in the last 15 years. That's it. But overall, the complication rate is close to 0. We use prophylactic doses, not treatment doses, so the risk of bleeding out or anything like that is really, really low. The issue, though, is it does hurt and it sucks. But I do use it a lot in my practice, and I know other fertility doctors that do as well, so I think you're right to ask about it, especially if you have a history of autoimmune issues. It may not be a bad idea. So someone's asking if an autoimmune consult is still needed if you have not done the recurrent pregnancy loss panel. And the answer is there are different panels that you can do. For me, it's looking at antiphospholipid antibody syndrome. I do sometimes check an ANA level. I would look at beta-2 glycoprotein, for example. So I don't think it's BS, but it's not necessarily indicated for everybody. But I think what your doctor is calling BS is the NK panel and looking at the cytokines like the TNF beta and those types of levels. And what I tell people is like, if it makes you feel good and you want to do it, let's do it. And everyone basically comes back abnormal for something in that panel. And then you have to do the treatment, because if I just told you that something was barely abnormal or abnormal, then you're going to think that because that term natural killer is so triggering, you will get these thoughts in your head that somehow your body's attacking the embryo. And I know automatically we all feel that way anyways. So I just always satisfy my patients' concerns and do the testing if they request it. But it is definitely not something that's in my toolbox that I go to at the very beginning. So this next question is, great one. What is the reason why a lot of follicles don't always make it during an egg retrieval? And I would say human biology. And it's so frustrating. And I wish that the IVF pyramid was better than that. If you don't know what I'm talking about when I'm talking about the IVF pyramid, go to there's two things you can do. Sign up for my IVF class because I go through it. My next one's on Monday. I'm a lot of fun in that class. I don't just drink coffee during the class. I tell way better jokes and I sing way better songs. I'm totally kidding. But it's just because not every egg will be genetically viable and be able to listen to the signals that we're sending them. And it also just depends on your age as well. So it has a lot to do with age, genetics, and then the environment, of course, of what you're going through. So next question is, what is the value of HCG that we can safely exclude a biochemical pregnancy or ectopic pregnancy? Great question, Joyce. It's not the HCG level. It's what's in your uterus. That's the thing. So you expect to see a pregnancy in the uterus when the HCG level is 1500. If you don't, it could be a pregnancy of unknown location, like an ectopic pregnancy or an abnormal pregnancy inside the uterus. So that's important to do. So as soon as your levels get above a certain level, get to your doctor and see what they can find. And I just got distracted by one of my favorite people, Kelly, saying hi. Hi, Kelly. I miss you. Next question is hysteroscopy necessary if the saline sauna was normal before a transfer? And the answer is, in my book, no. I know some doctors feel like the hysteroscopy is better, but everyone's clinic setup is different. And I do saline saunas a lot. Someone asked, is NAD the same as True Niagen? And the answer is yes. True Niagen is the bottle company name and it has NAD inside. Next question is this. I believe I got a new cyst after 2 cycles. Would this new cyst affect my egg quality? So the answer is, it depends. Is it endometriosis? Is it just a simple cyst? Probably isn't going to interfere if it's tiny. Okay, this is a great question. Is there a higher chance of autism in IVF doing FETs? I've read mixed reviews, and I would say no. No. But this is the thing. As we get older, there's an increased chance of having a baby with autism, right? And so that's what happens, unfortunately, when you're growing your family and you're even over the age of 35, but especially over the age of 40, and for sure if paternal age is over 50. So IVF doesn't cause the autism. It's related to what's in your genes, and your genetic makeup is related to things that are called epigenetic changes that can be age-related. So, I wish that there was an autism test, not that all babies are special and precious and wonderful, but I know that that's one thing that a lot of my patients worry about. So I get that question all the time. So the next question is, going through IVF cycle early next year with only 1 egg retrieval, 40 years old, AMH 1.3, FSH 11, any recommendations, genetic embryo testing recommended due to my age? The answer is yes. From Minnesota, yes. All those things, take all the good supplements, talk to your doctor about the egg whisper diet. What is your diagnosis? It sounds like you're a very healthy young woman with a great egg count being 40 years old. Plan your IVF protocol based on your diagnosis. Make sure you've looked at everything in the Tushy method too. Tubes, uterus, sperm, hormones, and your genetics. And then talk to your doctor about doing endometrial testing, like the ERA test and Receptiva test, and then go for it. Go for the transfer and hope for the very best. Okay, someone's asking, what is 3BB implantation rate for a PGT tested embryo? And the answer, PGT tested normal embryo, just depends on whether it's day 5 or day 6. That's part of my embryo diamond, so talk to your doctor about that. In my clinic, if you had a 3BB day 5, I would say at least 65% chance of implantation, at least. This question's from Ollie. My partner has 60% morphology and because of that, low fertility. We've been trying for 12 months. Is it possible that we can still conceive naturally and it might just take more time? So 60% morphology to me doesn't actually sound that bad. So I wonder if it's something related to the count or motility. So I would say get his sperm checked again. So you guys, there's a really cool DIY test, meetfellow.com/egg whisper. I get no money from the company, zero affiliation with them, but it's a cool test. They send the kit to your home. You do your thing, ship it back, and you'll get another semen analysis. Let's see what's going on. Same thing with the sperm DNA fragmentation test. You can also do it yourself. They send a big mushroom tank, and it looks like something that washed up on shore from Gilligan's Island, for those of you guys who know what I'm talking about. Okay, someone is asking, how much should one plan to spend on the egg freezing process entirely? So I would say probably around $15,000, which would really be a fair estimate. Next question, can I start stims with a period after an egg retrieval, like in 14 days after? Can I start stims again or should I wait a month? So it really just depends on your age and the number of follicles and your goals. So for me, I always say, I know I'm awesome. I'm super fun to be around, like see me 5 times in 2 weeks. I get it. You want to come back. But listen, like everyone needs a break from me. So I encourage a break in between cycles. However, if I have a patient, for example, that's over 40, we have about 3 follicles every single time, I'm just like, come in. As soon as your period starts, come on in, let's take a look at your ovaries and see what we have. And then we'll see, like sometimes you have a cycle that has more than 3 follicles and you're like, sweet, I'm glad I showed up. Other patients, psychologically, it's really hard for them to think about waiting a cycle. But I'm like, don't worry, just come in and we'll take a look. And if your ovaries are like, sweet, I'm not swollen anymore, all the bruising is gone, I'm ready to rock and roll, let's party. And then we can move forward. I love you. Saluda Moore is saying, ladies, just go to Dr. Aimee. Don't look north, east, or south. Look at west, San Francisco, Dr. Aimee. IVF is expensive and luxurious. Go to Dr. Aimee. Don't waste money with other doctors. Someone saying, when do you start and stop baby aspirin? So for me, I start baby aspirin at the time of estrogen start for a frozen embryo transfer. And then depending on your story, I stop it literally like around 34 weeks of pregnancy. We know that, with my patients, most of us are at higher risk of preeclampsia because of our age being, let's say, over 40. But also for a lot of my patients, this IVF pregnancy is their first pregnancy. And guess what? That increases your risk of a condition called preeclampsia. So starting aspirin, I think it's before 12 weeks of pregnancy, can decrease your risk of having preeclampsia. So that's why I stop it pretty late. Next question, is it normal to have or not have a period for 3 months after coming off the pill? So what I would say is if you haven't had a period after 3 months, there's something going on. So get checked, get your levels checked, get your AMH checked and find out, why your period hasn't started. What supplements should I take in preparation for IVF? So I strongly recommend a good prenatal like Theranatal from Theralogics. You can use code TUSHY, all caps. CoQ10, vitamin D, fish oil. So Theralogics, the Theranatal prenatal, has all of those things. And depending on your age and your diagnosis, there are other things that you can take like NAD and pterostilbene. You can also add Ovasitol, for example, if you have PCOS. So talk to your doctor about what they recommend for you. And sometimes if your doctor's like, I don't believe in supplements, don't worry, talk to your acupuncturist. I'm sure they'll have lots of great recommendations for you. Next question is, what is the impact of factor V Leiden on fertility or IVF treatment? So if you are heterozygous or homozygous, you're increased risk potentially of forming a blood clot. So I do prescribe Lovenox, which is a blood thinner, as well as aspirin to my patients who have that. And I strongly suggest that they stay on it throughout pregnancy, switch to heparin in the late 3rd trimester, and then switch back to Lovenox after delivery to prevent a blood clot in the immediate postpartum time frame. So talk to your doctor more about that. Someone's saying, you're an angel among us. You're a badass. Thank you. Thank you for everything you do. That's very sweet. Next question is Lupron and a patch along with adding PIO last week before FET, something you would do if the ERA results came back pre-receptive. Yeah, totally. Totally. Someone's saying, I just watched YouTube videos made by Dr. Aimee, so many, like an IVF encyclopedia. You guys, I'm not paying anybody to say these nice things, just so you know. Shika is saying, what are the chances of success with sperm DNA fragmentation of 28%? Just paranoid. So at 28%, I would say, ask your doctor if they have the ability to add extra technology. For example, Zymot, Pixie, or both. So that's one way of dealing with the DNA frag. And then look at the balls method. Background genetics, and you've already done the sperm DNA frag, so we'll skip that. Anatomy, rule out a varicocele. Labs like testosterone, see if the testosterone's low. Basically, see what you can do that's in your control to improve the DNA frag. Lifestyle, look at body size, look at exercise habits and nutrition, and then look at your sex life and see if there's any sign in there that something could be going wrong, like a low testosterone. And then the other thing, I just always have to talk about sex when I say S, it just naturally comes out. Supplements, look at the supplements that you could possibly be taking. So Steph is saying, Dr. Aimee, random question for me. I'm still in cycle and bleeding, but I just got a positive OPK. Is it possible to conceive naturally and still be on ant flow? And the answer is yes, Steph. That's the thing. Like, based on where you were in your cycle or where you're on your cycle, I have a feeling that the positive OPK could be a real thing. But at the same time, I would also say maybe the prolonged spotting or bleeding could be, I know it's a long shot, it could be triggering to do this, but maybe just check a pregnancy test just to be sure. And the reason is that sometimes a positive OPK can pick up HCG as well. It's probably a positive OPK, so please have sex. Have a sexathon and let me know what happens. Next question is, what's the difference between a PGT grading HBG and HBF, both normal day 6 embryos? So the HBG means hatching blast good, and the HBF means hatching blast fair. So the pregnancy rate difference between the two of them, ask your doctor. It's going to be different in every single lab, but I would guess it might be maybe a 10% pregnancy rate difference. So see what your doctor says about that. Next question is, I had 11 embryos frozen. I had 2 frozen embryo transfers, the 2 transferred each cycle. 1 ended in a miscarriage and 1 failed. My country doesn't allow PGT testing and ERA. How can I improve my chances? So that's a really good number of embryos. I'm sorry you had a miscarriage and 1 didn't work. I would say, I bet in your country you can do a complete miscarriage workup. So take a look at angelmethod.com or angelworkup.com. Go to the 5 things that everyone should know after they've had a miscarriage and see if you can rule out any of the things that are there. And then if you're not allowed to do any of the things that I talk about on this show, like PGT or implantation testing, ask your doctor if they've ruled out endometriosis. And it might make sense if you might have silent endometriosis or if you have symptoms to maybe treat medically before you transfer again. Let's see here. Next question is, for someone who's 33, what would you consider the success rate from an IUI with 11 million sperm count and 3 to 4 mature eggs by trigger? So an 11 million sperm count is on the low end. Depending on the motility, I would probably quote a 5 to 8% chance of pregnancy with 3 mature eggs. Tall guy is saying, no scotch or bubble baths? Kooky talk. Okay. Wendy is saying, I don't see cervical mucus like I used to and don't have sex drive like I used to mid-cycle. What could this be? What should I have tested? Testosterone? And the answer is, Wendy, I think stress is probably one of the things that it could be, and not enough foreplay. Ha ha ha, you guys say. Impossible, but literally foreplay starts the minute we wake up in the morning. I have really awesome partners that I talk to with, my patients, and they often ask, like, what can I do to improve our chances and help my wife or my partner? And I always say, you ask the 4 questions, and I bet your cervical mucus will get better. What can I do for you? How can I help you? What do you need? There should be a 4 somewhere there. Would you like a diamond? I'm not into diamonds, guys, but you know what I mean. So I would say the lack of CM and that kind of stuff and the sex drive, they're probably related. And I would say a lot of it might be stress related. If you're having healthy and regular ovulations, I wouldn't necessarily worry too much about it. But if you really want to study your CM, there actually is a device for everything. You can buy a KEGG, K-E-G-G, look it up online. You can literally place a cervical mucus monitor inside your vagina that tracks your cervical mucus and measures the quality if you really want to go that far. And a lot of people do. Next question is, CoQ safe to take while breastfeeding? Yes, just like it's safe to eat a spinach sandwich. What's the difference between NAD and NMN? If I'm not an expert in NMN or something, I'm not going to be able to answer that. But I think NAD is better. I don't know why. It just seems like it. But I know there's research to support NAD being better than NMN. But I'm going to look that up. Next question is, what's the difference between PGT and PGD? When do you recommend PGD? So PGT encompasses D. So PGT refers to the genetic testing platform, and then you can do A and M. A is aneuploidy, M is monogenic diseases. So PGD, we don't use that term anymore. We use PGTM instead of PGD. Next question is recommendations for egg donor banks and agencies. Absolutely. So I love Simplify with PNWF, Fairfax, World Egg Bank, Donor Egg Bank USA, and Ovation. Those are the 5 egg banks that I love working with. They make my patients parents. As far as egg donor agencies, I love My Donor Cycle, Nationwide Egg Donation, Golden Egg Donation. Those are a few of my faves. Happy Beginnings Egg Donation. Love them all. But I also recommend Tulip Fertility to you guys so you guys can have more options there. Great question from Joyce. Hi, Dr. Aimee. Is it okay to eat spicy food during early pregnancy after 4 weeks? The answer is if you're used to spicy food, it's okay to eat spicy food. If it upsets your stomach, save it. Britt is saying, I want to say I'm so grateful for these lives. Thank you. And her question is, I have 1 PGS embryo left and I did 4 FETs, 3 failed, 1 chemical. Do I try one more time? So I think it really just depends on your age. Maybe consider freezing more embryos, but if not, you could, let's say, do Lupron, it looks like from July to September, and I would add letrozole. So in cases of patients who have endometriosis or a positive receptiva, if I do Lupron, I actually have them take Femara all at the same time as well. So someone's asking, what are your thoughts on low dose protocols? And I think they're great. It depends on how many eggs you have, your age, your goals, how you feel on the medications. For people who have a lot of eggs, I don't necessarily do low dose protocols, but I always say that your priorities are mine, and we talk about the medications and how they make you feel. And some patients just don't want to feel like crap and don't want to feel super bloated, even though they have a lot of eggs. Someone is asking, is IVF not a great option for someone with DOR? And the answer is, I actually think it is a great option. It just depends on how old you are, how many eggs you have. I've definitely retrieved 1 egg from 1 follicle that's turned into 1 baby. I've definitely retrieved 20 eggs from 1 person that has resulted in no baby. So it's all about quality, not quantity. And I just don't want anyone to look back and wish they had done IVF when they still had eggs. Because at the end of the day, we all run out. 100% of us will run out of our eggs. Annie is saying, can improving gut health impact egg quality? And the answer is yes. I did a show with Dr. Alex on how your gut impacts fertility. So go to I think it's on my website already. Go to draimee.org, draimee.org, to the blog section. And I bet if you put gut health, you'll read the article that I wrote about that. Paula is saying, hi, Dr. Aimee. I'm 37, first IVF, 3 eggs all fertilized, 3-day transfer, 2 embryos and a chemical. Last embryo, fair, 8-celled, chances it will be normal with an AMH of 0.6. Okay, so at 37, I would say probably 25%. So I'm excited to hear what happens. I hope it works. You guys, I love you. I'm just going to answer the last 3 questions and then I'm going to go home. Cause why? It's official. Not only are my feet asleep for sitting for so long, my buns are asleep. And remember what I say, you're never alone if your buns have each other. So let's see here. Steph is saying, do you think it's possible that you can respond better without stems? I feel like I have better growth before I start FSH. Isn't that nuts? But the answer is no, meaning this. Our brain only sends enough of a signal to grow 1 egg. So it's hard to stimulate more eggs without FSH. Hi, Dr. Aimee. I just had my egg retrieval, 20 retrieved. The pain meds are wearing off. What else can I do? Take more pain meds. Call the doctor and say, I need more pain meds. Take Tylenol 1,000 milligrams with Motrin 600 milligrams. Place a heating pad. Start taking stool softeners down because believe me, the poop emergency can be worse than any pain that you're having right now. Let's see here. I'm going to go back to the last few questions. What sperm amount after wash are we hoping for in an IUI? My doctor made it seem like 10 million post-wash was great. In my mind, I love 20. Above 20. Below 20, I'm just like, kind of nervous. I'm 41, produced 8 embryos from 3 egg retrievals this year, but none of them passed the PGT testing. Should we keep going? And when I tell patients who are over 40 trying IVF, it might take 4 to 6 cycles to even get 1 healthy embryo. So keep trying. As long as financially it doesn't completely bankrupt you, because a lot of times it can, and we don't want that to happen. And ask yourself the question, would I feel better going through a donor egg cycle than having another failed IVF cycle? And if the answer is still no, then keep trying with your own eggs. But that's just the reality. There's nothing wrong with you. You're just a normal woman who's over 40. It's just super hard, super hard to get pregnant over the age of 40 for everybody, no matter how smart you are, how great your doctor is. It's just the reality of it. Okay. Love you guys. I don't want you to miss me. So surprise, surprise, I'm going to be here again, probably tomorrow. So I hope you'll all tune in. I hope you learned a little bit or learned a lot about some of the suggestions that I have made. I don't have many deep thoughts tonight, but I feel like lots of people have been talking about farting. Are you guys feeling gassy? Not me, but a lot of my patients have been telling me how gassy they're feeling from I feel like every conversation I had today was like, I'm gassy, I'm pooping. Is this normal? I'm pooping a lot. Just wanted to make you guys laugh a little. before I signed off. Okay, love you guys. Keep sparkling, and I'll see you guys tomorrow. Bye-bye.